So the skeletal system. I don't know what comes to your mind when you hear skeletal system, but perhaps you've heard about this all the way from primary school, high school, and now you're hearing it again. My intention is not to really repeat a lot of things that you already know, but to try to take the discussion at a level that is now considered tertiary. These are the things you're going to learn in the skeletal system. We had already talked about the histology of bone tissue. We'll just have an overview of that again. We also talked about modes through which bone growth occurs, and we'll review that. We talked about types of cartilages histologically, and we'll review that. After those three reviews, then we'll focus on the subject matter, the divisions of the skeletal system. We are then going to look at the bones of the axial skeleton, that's the axial division, and also the bones of the appendicular division. Then, in terms of developmental anatomy, we are going to look at congenital malformations of the axial skeleton, because congenital malformations of the appendicular skeleton we will do when we are going to do the limbs. So we'll handle that when we are looking at anatomy of the limbs from a topographic perspective. So you realize that in this lecture, we are combining gross anatomy, histology, and embryology. And that's the essence of doing anatomy from a systemic perspective. You consolidate the three divisions of anatomy together. So in terms of bone tissue organization, these ones I'll be quick, the reviews, because we had done them before. In terms of bone tissue organization, we say that bone is a specialized connective tissue because it has heavily mineralized matrix and that the matrix contain less water. In terms of functions, we mentioned that bone will provide structural support to the body. This is the one that now forms our framework. It also protects internal organs like the heart is protected by the ribs, the skull protects the brain, the vertebral column protects the spinal cord. We talked about bones working together with muscles to help in movement, the one they cause across joints. Inside of the bone, we have bone marrow, which is a site of intramedullary hemopoiesis, formation of blood within bone marrow, intramedullary hemopoiesis. And we mentioned that the bone matrix contains a lot of calcium, and this therefore forms an important reserve for calcium ions. Over 90% of calcium is in bone. In terms of coverage, we mentioned that bone is covered by a connective tissue membrane that we call the periosteum. Now, periosteum has two layers. The outer layer of the periosteum is fibrous and contain blood vessels. That layer is largely for nutrition. The inner layer of the periosteum is cellular. This inner layer is largely for growth of bone tissue. So the one for growth is largely the inner cellular layer. That's where cell division occurs. The one for nutrition is largely the outer fibrous layer, the one with the blood vessels. That is covering of bone. The outer covering is called periosteum. The inner covering, there's something similar to periosteum, but on the inner side. So the layer on the inner side is called endosteum. The one on the outer side is called periosteum. We mentioned that there are two types of bone tissue. We have cortical bone, which look like this, does not have marrow cavity and tends to be external. Then we have cancellous bone, which looks like this region here. It contains bone marrow. It has several trabeculi, that's why we call it trabecular bone. And in as much as we call it spongy, it is not necessarily a sponge. That name is largely because of the appearance. I'm asking you a question now. So this question is not in the poll. You'll respond directly via chat to me. That's the question. So your answer is either A, B, C, or D. You can respond now. So I can see you people have responded. And I've realized that there's no correct answer there. Like those choices given, there's no correct response. Okay. Let's talk about bone tissue growth. How does bone grow? There are two ways in which bone growth occurs: intramembranous growth or endochondral growth. We said intermembranous growth is when you have a connective tissue membrane that then form bone, and that's how flat bones will form. Endochondral growth is where you form cartilage first, which is then replaced by bone, and that's how long bones form. Parts of a long bone. The shaft of a long bone is known as diaphysis. This is how the diaphysis will look like radiologically. This region or there. The ends of the long bone are called the epiphysis. This is the distal epiphysis of femur. This is the proximal epiphysis of tibia. This broad region here is called the metaphysis. It is the end of the epiphysis. Sorry, it's the end of the diaphysis. Is what we call the metaphysis. Then, this radiolucent region here that looks like a fracture, that region there, appears so because it contains cartilage. We call it the growth plate. The growth plate contains cartilage. It's also called the physis. That is why this is then called epiphysis. This is diaphysis between the physis. That is bone tissue. There are other things we mentioned about bone tissue. We talked about the lamellar systems in bone. We mentioned bone cell types and their specific functions. You remember them. Let's say something about cartilage, what we said about cartilage. Some properties of cartilage that we talked about that time, we said cartilage is resilient, it's also flexible, doesn't have blood vessels, it has a lot of collagen type 2, and it has low metabolism. can be found in many places, but we preferred mentioning where cartilage is found based on the type of cartilage involved. So we talked about 3 types of cartilage. We said there's hyaline cartilage, and that hyaline cartilages had some unique histological features, one of them being a uniform matrix. The cells of hyaline cartilage are smaller, and hyaline cartilage has perichondrium. We talked about the distribution of hyaline cartilage, and we mentioned that it is found in the airways, in articular surfaces of synovial joints, the ends of ribs, and that's what we call costal cartilages, the skeleton of the fetus, and lastly, the growth plate of long bones. That is hyaline cartilage. We talked about the elastic cartilage, and we mentioned that elastic cartilage has a lot of elastic fibers. That's why we call it elastic cartilage. It also has large cells compared to the previous one. These ones are larger. And usually elastic cartilage also has perichondrium. Perichondrium is a covering of cartilage, the same way periosteum is a covering of bone. In terms of distribution, we said that this is found in the epiglottis, it's found in the pin of the ear, and we find in the ala of the nose. The last type of cartilage we mentioned was fibrocartilage, which has fewer cells basically, and a lot of connective tissue fibers. This is fibrocartilage. Usually fibrocartilage does not have the perichondrium. In terms of distribution, we saw that it is found in the intervertebral discs, specifically the annulus fibrosus of the intervertebral disc. The menisci of the knee are the discs within the knee, where tendons attach to bone, the margin of the acetabulum, as well as the margin of the glenoid cavity. The glenoid cavity is the socket of the shoulder. These are the regions where we find fibrocartilage. We had talked about this. Okay. I want to ask you a question. This one you are doing in your groups, in your breakout sessions. So I am dividing you into your breakout sessions. You'll have 3 groups. Okay, let me make them. How many are you now? Okay, I'll divide you into 4 groups. Some of you will be 4 people, some will be 3 people. Sorry, 5. So accept the group that you're in and answer the question projected. You're talking about the difference between cartilage and bone tissue. So I believe you've well reminded yourself about the differences between cartilage and bone tissue. Now let's look at the subject matter of today, actually. What you've done was just review. Now we can focus on what we are supposed to do today. We divide the skeletal system into 2, the appendicular skeleton and the axial skeleton. When we talk of appendicular skeleton, we are referring to the bones in the limbs. When we talk of the axial skeleton, we are referring to the bones within the body axis. We'll start with the axial skeleton, the bones in the body axis. So when you're referring to the axial skeleton, you are referring to this one, which is the skull. this one, which is the vertebral column, this one, which is the rib cage, and lastly, a tiny bone that we're not seeing in this one, but usually located in the neck, we call the hide bone. Let's look at these 4 categories of bones one by one. We start with the skull. The skull is what we're calling the cranium. This is the skeleton of the head. So the head skeleton is divided into 2. There are those bones which house the face. We call it the visceral cranium, the bones that house the face. The bones which house the face can therefore be still called facial cranium. So which bones are housing the face here? So this one, zygomatic bone. This one, maxilla. This one, mandible. If you forget any other bone of the face, please don't forget those 3. Zygomatic bone, maxilla, mandible. Maxilla is the upper jaw. Mandible is the lower jaw. Zygomatic bone is the chin bone there. But there are other bones that form the face. You can add the nasal bone there. There are palatal bones. There are bones here in the nasal septum. They're still part of the bones of the face. But at least don't forget the first 3 big ones that I've told you about. Those are bones of the face. You still see the bones of the face in this view: mandible, maxilla, zygomatic bone, nasal bone. Apart from bones of the face, the other category of bones of the skull are now the bones which house the brain. Remember, the brain is somewhere here. So the bones that house the brain, that region I am encircling, refer to the bones which house the brain, which we now call the neurocranium. So we have visceral cranium and neurocranium. Neurocranium is divided into 2. Look at this outline I'm giving you. This is the neurocranium. We divide neurocranium into 2. There are those bones which are on top of this line I've drawn there. So they form the top of the neurocranium. The bones that form the top of the neurocranium are known as the calvaria. The calvaria refers to the top of the neurocranium. You can therefore call it the skull cap. These bones are the ones which develop from intramembranous ossification. So we also call it the membranous neurocranium. The membranous neurocranium consists of the parietal bone, frontal bone, occipital bone, temporal bone. Now, I want you to understand that apart from parietal bone, the other bones that we've talked about has many parts, some of which are not necessarily in the calvaria. As you can see here, the frontal bone extends beyond that line down, similar to temporal bone as well as occipital bone, which means part of those bones actually lie below that line, will be lying in the base of the skull. But they also have parts which are in the calvaria, the top of the skull. Parietal bone is entirely within the membranous neurocranium. So the bones which are below that line, where are they? They form the base of the neurocranium, and so we call it the chondrocranium. The reason we call it chondrocranium is because these bones develop from cartilage model, from endochondral ossification. You can call it chondrocranium or the skull base. There are many bones in the skull base. This is the petrous bone. It is part of the temporal bone. This is the basilar bone. It's part of the occipital bone. These are the condyles, which are part of the occipital bone. Mastoid bone, part of temporal bone. Sphenoid is a standalone. It's a bone of its own, but it has many parts. Like this is the sphenoid bone. So these plates you're seeing there are actually part of the sphenoid bone, but largely a big part of the sphenoid bone is in the skull base. Ethmoid bone is not well visualized from this view, but it's also one of the bones of the skull base. So point here is that the skull base, the bones originate from cartilage. The skull cap, the bones originate through intramembranous ossification, and they're all parts of the neurocranium. If you were to look at this from the skull of a fetus, there are some unique features that we'll highlight. But before I talk about those unique features, there's some terminologies that we also use when we're describing the regions of the fetal skull. From this point up to just the regions of the eye, that's what we call the face, now that you already know. From that ridge to where the frontal and the parietal bones meet, we call that the brow. From where those meet to where the occipital meets parietal, we call that the vertex. And beyond that, that's what we call the occiput. So those are the regions of the fetal skull: face, brow, vertex, and occiput. When you start your midwifery rotations, you will remember this story. You'll be required to know how the baby is coming during delivery. Is it a face presentation? And so what do you do about that? Is it a brow presentation? And what do you do about that? Is it vertex presentation, or is it occiput presentation? You may not necessarily have occiput presentation, may not be practical, but a number of times you'll come across the first three. The normal fetal presentation is the vertex presentation. Those ones will deliver vaginally. Brow might be difficult, face will not deliver vaginally unless you change the orientation of the fetal head. And so it's very important that you know how the baby is coming. Let's talk about some unique features of the fetal skull. This is especially compared to the adult skull. And I want you to think through this first before I give you the answers. So think about it. What are some of the differences between the skull of a fetus and that of an adult? You have a minute. So let me take you through it. First, of course, there's the issue of size, which I don't want to emphasize on. So apart from size, what are some of the differences? I want to look at the junction between the bones. The junction between skull bones, the joints between skull bones are called sutures. The sutures are wider in the skull of a fetus compared to the skull of an adult. I want you to look at the junction between two or more sutures, like this is a junction, this is a junction, there's a junction, and this one here is this one. But this is a junction between two or more sutures. And what do you notice? That the junction between two or more sutures are wider still. These junctions are known as fontanelles. There are 6 fontanelles on a fetal skull or a neonatal skull. The largest fontanelle is this one, which we call the anterior fontanelle. Fontanelles are covered by membranes. They are junction between two or more sutures. They are covered by membranes. They are wider. The anterior fontanelle is the one I'm pointing at. This anterior fontanelle usually close at 18 months. So it will be present up to 18 months. That's when it closes. You've most likely seen babies when they're breathing and then look at the top of their head, something dancing. That's anterior fontanelle. Anterior fontanelle is important clinically. You can use it to make some diagnosis. For example, a child might be brought to hospital. You look at the anterior fontanelle and the anterior fontanelle is bulging. In another scenario, you may see this child, okay, a different one maybe, and the fontanelle is sunken, it's deepened. So I want you people to tell me, if the fontanelle is bulging, what could be the problem? And if the fontanelle is sunken, what could be the problem? So feel free to unmute yourself and you can answer any of them. A bulging fontanelle, what could be the issue? A sunken fontanelle, what could be the issue? Anyone?
A bulging fontanelle can be as a result of increased intracranial pressure.
Very good. I agree with you. When you see bulging fontanelle, it's definitely because the pressure inside is increased. And I want us to build on that, Jemtai. Thank you for bringing that concept up. So what would then cause the pressure within the cranium to increase? What would cause increased intracranial pressure? Anyone?
Build-up of fluid in the brain.
Very good, Jenny, and that is what we call hydrocephaly. So hydrocephaly is one of the causes of raised intracranial pressure and so a cause of bulging fontanelle. Apart from hydrocephaly, sorry?
Bleeding in the brain.
Okay, you may have bleeding into the brain. That's true. I agree with you. Although that will be a very minor cause, it will depend on how it has bled. If the bleeding has caused obstruction of the CSF flow, then it will give you bulging. Great. Anything else?
Brain tumor.
Very good. Brain tumors will also cause that bulging, again, through the same mechanism, blocking the CSF flow. Anything else that can give you a bulging fontanelle? Brain tumor, bleeding, or hydrocephaly itself? Anything else?
Brain injury.
Okay, you need to specify which type of brain injury.
Swelling of the brain.
Okay, brain edema. Brain edema. That could be a result of brain injury. Well, now I want you to remember this. If you're ever asked possible causes of bulging fontanelle, there's some two things that you must mention as a cause of raised intracranial pressure, and especially in children. After that, you can mention anything else. One is hydrocephaly, and the second one is meningitis. If there is infection inside, the fontanelles will bulge. Once you've mentioned those two, you can mention anything else, not a big deal. Right, how about if the fontanelle is sunken? It simply means that the pressure inside is low.
Dehydration.
Okay, good. So Jemtai, one of the causes of lower intracranial pressure is dehydration. And perhaps it means that this child has been having diarrhea for long or has vomited for long. Then you have sunken fontanelles. Now you know how to make diagnosis of dehydration in children. Okay. Apart from bulging and sinking of the anterior fontanelle, we can also use fontanelle to image the fetal brain, to image the neonatal brain using ultrasound. Ultrasound imaging, you know, ultrasound doesn't pass through bone. So when you image the brain through here, you won't see much. And that's why you don't do brain ultrasound on an adult. But on a neonate, you can actually do. You know, in adults, you can do CT scanning, which uses radiation. But in children, you try to avoid radiation as much as possible. The advantage here is that we can do ultrasound instead through the anterior fontanelle. Apart from anterior fontanelle, we also have this one, which we call the posterior fontanelle. It closes at about 2 to 3 months. Then we have this one, which we call the anterolateral fontanelle. These ones are bilateral, so right and left. This one, posterolateral fontanelle, which is also called mastoid fontanelle, again bilateral, right and left. So these two are paired. These two are midline. That makes them 6. I haven't told you when the sphenoidal and mastoid fontanelles close. You can check that on your own. What is important to note is that the skull of a neonate has fontanelles, and the skull of an adult does not have fontanelles. Now back to those fontanelles. If the skull of an adult does not have fontanelle, then what will it have instead? The anterior fontanelle becomes what we call the bregma. So adult skull will have what we call bregma instead of anterior fontanelle. Posterior fontanelle becomes what we call lambda. From this term lambdoid, you get lambda. It's a Greek letter, I think you know it. The sphenoidal fontanelle becomes what we call pterion. Pterion is written as P-T-E-R-I-O-N. P-T-E-R-I-O-N, pterion. Posterolateral fontanelle becomes what we call asterion. So it's AS pterion without P now. AS pterion without P. Asterion, one word. All right. Those are fontanelles. Apart from fontanelles, another difference between the skull of a neonate and that of an adult is the presence of this suture here. We call metopic suture. The metopic suture is not present in the skull of an adult, but it is present in the skull of a neonate. This suture usually disappear at the age of 2 years. In some people, it may persist even up to 7 years, but mostly it disappears by 2 years. So it's present up to 2 years, then now fusion occurs from 2nd up to 7th year. I think that's a better way of explaining it. All right, there are some differences which are very obvious and you shouldn't miss them. Things like the skull of a neonate does not have teeth and that of an adult has teeth. The skull of a neonate, look at the facial cranium. The proportion occupied by the facial cranium is very tiny. The facial cranium can actually enter the neurocranium 8 times for a neonate. That means that the ratio of neurocranium to facial cranium is 8:1. But the ratio of neurocranium to viscerocranium in an adult is about 8:3. The neurocranium is still bigger, yes, but at least facial cranium grows faster after birth to try to compensate for its small size. And this is largely contributed by the growth of the teeth, growth of some air cavities within the bones of the facial cranium. We call them paranasal sinuses. There are cavities within the bones that surround the nose, paranasal sinuses. They form after birth. Another big difference is on the type of skeleton that is on the skull base. In a neonate, it is predominantly cartilaginous. But in an adult, the skull base is bony because ossification has occurred. There are other differences that you can check later, not a big deal. And so if you want to get that, that's what you'll serve. You just look at anatomical differences between the skull of a neonate and that of an adult. There are many other differences you can talk about, but please remember the ones I've told you. Okay, as we finish the skull, let's talk about some congenital anomalies of the skull. We can have a scenario where the brain did not form, so the skull did not form. We call it cranioschisis, perhaps the most severe form of CNS malformations. Sometimes the brain has formed, but the skull has not formed. That's what we call acrania, absence of skull. Chisis means split. So split skull and absence of skull. I'd mentioned to you the concept of encephalocele. If it happens in the frontal side, you call it frontoencephalocele. If it happens posteriorly, then you call it occipital encephalocele. You can also have abnormalities of premature closure of the skull sutures. This suture here is called the sagittal suture. If the sagittal suture closes prematurely, you'll have a skull or a head that looks like this. And this is what we call scaphocephaly. It is one of the types of craniostosis. This suture here between the frontal and the parietal bone is called the coronal suture. If that suture closes prematurely, you get a skull which looks like this. And this is what we call brachycephaly. Again, it's one of the craniostosis. Okay, we're done with one of the bones of the axial skeleton. Let's go through the second bone of the axial skeleton, the vertebral column. The vertebral column is also called the spine. Don't confuse spine with spinal cord. Spinal cord is called so because it's a cord within the spine. It is a cord of the spine, spinal cord. Here we are talking about spine. The spine is a vertebral column. Vertebral column has three basic components. You have the vertebral bones. These are the vertebrae. The joints between the vertebrae are known as intervertebral discs. And there are vertebral ligaments, several of them. The ligaments join the different vertebral bones. Let's start with the vertebrae. So there are several vertebrae in the vertebral column, a total of 33 vertebrae. These 33 vertebrae are divided into segments. We have 5 segments of the vertebral column. The cervical segment is a segment within the neck, has 7 cervical vertebrae. We name them as C1, C2, C3, up to C7. The term C here refers to cervical. Specifically, the C1 vertebra has a name. The C2 vertebra also has a name. Who remembers the name given to C1 and C2? Anyone? Nobody? Okay. So C1 is what we called the atlas in high school. C2 is what we call the axis in high school. Unless, I think the syllabus may have changed. But yeah, that's what we used to call them those days. Then we have the thoracic segment. The thoracic segment has 12 vertebrae. We name them as T1 up to T12. As the name suggests, this refers to the region in the thorax. Then we have the lumbar region. Lumbar segment has 5 vertebrae, named as L1, L2, up to L5. we have the sacral segment. The sacral segment has 5 vertebrae, but these vertebrae are fused. We have S1, S2, S3, S4, and S5, but they are fused together. Good. I want you to do your arithmetics and tell me, so the last segment, which is the coccyx, will have how many vertebrae? Aya, changamkia.
4.
Very good. The coccygeal segment has 4 vertebrae. We abbreviate coccygeal segment as shown there. And we have 1 to 4. Again, the vertebrae in the coccygeal region are also fused. So these are the vertebrae segments. The vertebral column is not very straight. Actually, it is not straight. But if you look at it from anteroposterior view, it will be straight like this one. If you look at it from a lateral point of view, it will have some curvatures like this one. This is a lateral view, this is an AP view. So AP view, the vertebral column should be straight. A lateral view, the vertebral column should have anterior and posterior curvatures. We described 2 types of curvatures in the vertebral column. This is what we call the primary curvature. The primary curvature is the curvature that formed while this baby was still a fetus. So the primary curvature forms before birth. And what causes the primary curvature to form is the craniocaudal embryonic folding. It's a result of craniocaudal embryonic folding, or what we must have called last time, folding in the sagittal plane. The term given for primary curvature is kyphosis. The kyphotic curve is this one here, which is concave in front and convex posteriorly. It forms as a result of craniocaudal folding of the fetus. That type of curvature, the primary curvature, persists in not all the segments of the vertebral column, but some segments. The segments that retain the primary curvature is this one, the thoracic segment, as well as the sacrococcygeal segment. Sacrococcygeal segments and the thoracic segments retain the primary curvature. They retain the kyphotic curve. On the other hand, secondary curvature is a curvature that forms after fetal life. This secondary curvature develops as an adaptation for some positional changes that the baby now needs to undertake. When a baby is born, they're not able to support their neck at that point. They can't support their head. Such a baby, if you force them to crawl, they'll drag their head on the ground. As a preparation for ability to crawl with the baby facing forwards, the curvature in the neck needs to behave in a different way. So instead of being concave anteriorly, it will be convex anteriorly so that this head can actually face the front when the baby is crawling. So basically, secondary curvatures are convex anteriorly. or we can say they're concave posteriorly. Secondary curvatures are known as the lordotic curvatures. They're present in the neck and lumbar region. Cervical lordosis is this one. Is an adaptation for head support to enable the baby face forward when they're crawling. So this must happen before the baby starts to crawl. Actually, it happens even before the baby knows how to sit. Because if they sit with the head falling down, every time they'll be choking when they're sitting. Cervical lordosis develops between the first 3 months of life. From the first to the 3rd month of life, that is when cervical lordosis develops. As opposed to the lumbar lordosis, which is an adaptation for the upright posture. This lordostic curve, therefore, will develop much later, just before the baby starts to stand with support. But it develops over a long period of time. Lumbar lordosis develops between the 9th to the 18th month after birth. Great. Those are the curvatures of the spine. Remember, anterior, posterior curvatures are normal. Lateral curvatures are abnormal. Let's talk about parts of a vertebra. A vertebra has a body, which is also called the centrum. From the body, there are 2 elements that go posteriorly. We call those ones the pedicles. The pedicles also has some projections which go like that, which we call the lamina. The junction between lamina and the pedicle has this bony projection, which we call the transverse process. Where the 2 lamina meet is this projection, which we call the spinous process. Look, from here all the way to here is what we call the vertebral arc or the neural arc. During development, this neural arc comes like this, and this neural arc comes like this. They meet somewhere in the middle, then they form the spinous process. By doing so, they enclose the spinal cord here. This region here is what we call the vertebral canal. And that's where the spinal cord will run through. We're done with the vertebrae. Now let's talk about the intervertebral discs. Intervertebral discs are joints between vertebral bodies. Each disc has 2 components. The outer part is a fibrocartilaginous structure, which we call the annulus fibrosus. The central part contains mucous tissue, a remnant of the notochord. We call it the nucleus pulposus. A question to you: how many intervertebral discs are present in a human? I've already told you the number of vertebrae present. Now tell me how many intervertebral discs are present. And I want you to just write in the chat there. I've made in such a way that whatever you write will be seen by everyone. So just proceed. Kuna wenye wameandika rumors, but ni sawa tu. Let's talk about congenital malformations of the spine. One of the common congenital anomalies of the spine you're going to come across is this one. This is the atlas. It doesn't have to be atlas, it can be any vertebra. You can see that the vertebral arc is having a defect there. This is what we call spina bifida. You can have spina bifida without a swelling. And that type of spina bifida without a swelling is the one you had called earlier spina bifida occulta, as opposed to spina bifida with a swelling, which you now call meningocele or myelomeningocele, depending on what is inside. This is showing you myelomeningocele. Myelomeningocele. So this is the concept of spina bifida, that the vertebral arc or the neural arc has a defect, it's not complete. If it has a defect, but there's no swelling on the skin, then we call it spina bifida occulta. The term occult means hidden. If there is a defect, yes, and there's a swelling, then we call it cystica. So this one and this one are spina bifida cystica. When you have spina bifida cystica, then it matters to know what is within the cyst. The one that contains CSF with meninges only is called meningocele. The one that contains CSF meninges together with the neural tissue is called myelomeningocele. You can call it meningomyelocele or myelomeningocele. You did this under neurotube defects. So this is showing you spina bifida occulta. There's a defect, but there's no swelling. Cystica, this is meningocele, this is myelomeningocele. You can also have malformation of the spine where a vertebra has formed only on one side. This is what we call hemivertebra. Someone with a hemivertebra will appear like their vertebral column is not straight from the AP view. Remember I told you that the spine should be straight from AP view. So if it's not straight from AP view, then we call it scoliosis. So clinically what you'll see is scoliosis. The lateral curvature of the spine is called scoliosis. Scoliosis is abnormal curve. Lordosis can be normal or abnormal depending on where it's occurring and the degree of the lordosis. Kyphosis can be normal or abnormal depending on the degree or even the site of the occurrence. But all types of scoliosis are abnormal. I want you people to look at this radiograph, these three radiographs. They are of three different patients, but they all show the same congenital malformation of the vertebral column. Look at them, then someone try to tell me which congenital malformation of the vertebral column is anyone seeing? You can try, anyone? No one wants to try here, okay. I know when you'll try once that timetable for the exam comes out. This one here, is absence of the sacrum. There's no sacrum in any of the bones. So we call it sacral agenesis. You can also call it caudal dysgenesis. We talked about it when we were looking at gastrulation. Now, in this one, this is the normal way in which the cervical spine should be. In this one, the cervical vertebrae are fused together. We call this Klippel-Feil malformation. Fusion of the cervical vertebrae. Klippel-Feil malformation. I put a normal one there so that you know that intervertebral disc spaces should be well visualized. Here you can't see the intervertebral disc spaces. Great. Maybe you need some rest kidogo. So 5 minutes break. When we come back, we proceed from the rib cage. Well, we can resume now. So remember, we are looking at skeletal system. We have said that we have axial skeleton and appendicular skeleton. And for the axial skeleton, we have the skull, we have the vertebral column, we have the rib cage, and we have the hide bone. We've already looked at the skull and the vertebral column. So let's look at the third component of the axial skeleton, which is the rib cage. So the rib cage consists of 3 components. We have the sternum, the costal cartilages, and the ribs. Let's begin with the sternum. The sternum is this bone here. It has multiple parts. This is the manubrium of the sternum. This is the body of the sternum. This is the xiphoid process of the sternum. This one here is called the sternal angle, which is also called the angle of Louis. The sternal angle is a junction between the manubrium and the body of the sternum. About the ribs, we have 12 pairs of ribs. Whether you are Adam or Eve, the upper 7 pairs of ribs are the ones we call the true ribs because their cartilages reach the sternum. The lower 5 pairs are called false ribs because their cartilage do not reach the sternum. For rib number 8, 9, and 10, their cartilage joins the cartilage of the rib above. So the cartilage of 8 joins the cartilage of 7. The cartilage of 9 joins the cartilage of 8. And the cartilage of 10 joins the cartilage of 9. Their cartilage joins the cartilage of the rib above. That is for rib number 8, 9, and 10. For rib 11 and 12, they are called floating ribs because their cartilage don't join anything. Remember, there are a total of 12 pairs of ribs, whether you are Adam or Eve. The cartilage at the ends of the ribs are the ones you're calling costal cartilages. Costal cartilages are hyaline type of cartilage. Let's talk about some congenital defects that affect the rib cage and the sternum. Commonly, you can have a rib that is arising from the cervical vertebra. We call that cervical rib. You may also have a cleft in the sternum. We call that sternocleft. You may have a sternum that has gone inwards. We call that pectus excavatum, excavation. The opposite is also possible, where the sternum has projected outwards. We call that pectus carinatum. Pectus carinatum is also known as pigeon chest. We see this in some congenital heart diseases. The last component of the axial skeleton is the hide bone. The hide bone is located at the level of the larynx. The larynx is somewhere here near your Adam's apple. The hide bone is not really continuous with the other parts of the axial skeleton, so it's largely for attachment of muscles of the larynx. The muscles of your voice box attach in the hide bone. Clinically, it's an important bone because when someone is killed, let's say by strangulation, commonly this bone will fracture. And so in postmortem, it becomes a very important bone to determine the cause of death. If you find someone, let's say, in a river or maybe burnt, you still want to find out whether they were killed before that happened or not. And this is one of the things to do, to check, to determine cause of death for a person. That marks the end of the axial skeleton. Now I want to quickly take you through the appendicular skeleton, and then we'll call it a day for today. Appendicular skeleton refers to the bones of the limbs. They could be bones of the upper limb or bones of the lower limb. Bones of the lower limb are the ones I'm starting with. So these ones, we call them pelvic girdle. This one, femur. This one, patella. This one, tibia and fibula, the bones of the leg. Then this one, bones of the foot, they are multiple. Let's go through them. We start with the pelvic girdle. So pelvic girdle is a bone of the gluteal region. There are three bones that form the pelvic girdle. The one labeled A is the ilium. The one labeled B is the pubis. And the one labeled C is the ischium. This is ilium, this is pubis, and this is ischium. The three bones meet in this socket labeled Y, which we call the acetabulum. This is the acetabulum. The right and the left pelvic bone meet in this region here, labeled X, which is the pubic symphysis. And this is the pubic symphysis. It is radiolucent because this is cartilage. The iliac bone articulates with the sacrum in this region here called the sacroiliac joint, which is this one, sacroiliac joints. Beyond that, we go to the bone of the thigh, which is the femur. The femur has a head labeled 1, neck labeled 3 here. The lesser trochanter labeled 4. These are the greater trochanter. The whole of this is the shaft of the femur. These two labeled 7 and 8 are the condyles of femur. So here, this is the head of femur, this is the neck, greater trochanter, lesser trochanter, and this is the shaft of femur with lateral and medial condyle of femur, the bone of the thigh. Anterior to the knee joint, we have the patella bone. This is patella. The base of the patella is usually up, the apex of the patella down. This is the patella, that's the patella. The kneecap. Bones of the leg, we have tibia and fibula. Tibia is a bigger one, fibula is a smaller one. Although fibula might be taller actually, but slender. The upper end of the tibia has those rounded ends, which you also call the tibial condyles, medial condyle, lateral condyle. This is the head of the fibula. So if you look at them here, this is still tibia, this is fibula. If you see this line, it tells you that this is skeletally immature. So that's a growth plate, as opposed to this one, which is mature. The projections of the tibia down is called the medial malleolus. The projection of the fibula down is called the lateral malleolus. Bones of the foot. We have 3 categories of bones. We have tarsal bones, metatarsals, and phalanges. Starting the tarsal bones, there are a total of 7 tarsal bones. Two of them are very big. This is talus and calcaneus. The talus is big. The talus is bigger than the calcaneus. Sorry, the calcaneus is bigger than the talus. The calcaneus is the one that forms the heel bone. This one here is calcaneus, is the largest tarsal bone. It forms the heel bone. The talus is the one that articulates with tibia and fibula. It is the one that forms the ankle joint. These 2 bones are proximal tarsal bones. Then these tarsal bones, which are in the middle there, you can check their names: navicular, cuboid, and cuneiforms. They are medial, intermediate, and lateral cuneiform. Those are tarsal bones, a total of 7. Then you have metatarsals, which are 5, and phalanges. Now, phalanges are a total of 14. Don't be tempted to say 15. The big toe, similar to the thumb, has only 2 phalanges, as we can see here: the proximal and the distal phalanx. But the other 4 toes, just like the other 4 fingers, have 3 phalanges each: proximal, middle, and distal phalanx. So a total of 14 phalanges in each foot. Now you can be figuring out how many bones are there in the foot. Whatever number you get, you'll add others, because there's some bones I've not talked about. There's some bones which we call them sesamoid bones. You can look at them from this radiograph. You can see one tiny one there. You can see 2 here. There's one here. There's another one there. Those are called sesamoid bones. So there's usually many bones in the foot. Many bones. You can see sesamoid bones there. Sesamoid bones are bones which look like seed-like bones. Tiny, they are along the tendon of a muscle. So this would be the foot radiograph of a child. That's why you're not seeing many of the tarsal bones, because they are still cartilaginous. This is skeletally mature. Let's now talk about bones of the upper limb. So bones of the upper limb, we have the pectoral girdle, which is this region here. We have the humerus, we have radius and ulna, and we have the hand skeleton. Let's begin the pectoral girdle. The bones of the pectoral girdle are two. We have the scapula, which you're seeing here, also called the shoulder blade. This is the inferior angle of the scapula, superior angle of the scapula. This is the glenoid of the scapula. This the glenoid still. This is the spine of the scapula ending onto the acromion process, which is this one. This is the coracoid process of the scapula, which is this one. So that's the scapula or the shoulder blade. Anterior to the scapula is the clavicle, which is the collarbone. The clavicle has a flat end, the lateral aspect, and the rounded end, the medial aspect. So this rounded part articulates with the sternum. This flat part articulates with the acromial process at the acromioclavicular joint, which is that. Humerus has a head which articulates with the glenoid of the scapula. Humerus is described to have two necks. The one labeled 2 is the anatomical neck where the capsule attaches. The one labeled 3 is the surgical neck, the one most prone to fractures. This is the shaft of the humerus. Down here, articulating with the bones of the forearm, there are many structures there to talk about. Either way, that's the distal humerus. Then we have bones of the forearm, which is radius and ulna. The radius is shorter than the ulna. The ulna has a notch. The radius has a rounded head proximally. That's how you distinguish them. So this would be ulna, this would be radius. This is radius, this is ulna. This is ulna, this is radius. Radius is longer. The radius is the one that will be medial. Sorry, the radius will be lateral here. The ulna will be medial. That is why radial means lateral and ulnar means medial. Those bones articulate with the humerus at the elbow joint and with carpal bones at the wrist joint. So let's talk about the bones of the hand then. Just like for the foot, there are 3 categories of bones of the hand: carpal bones, metacarpals, and phalanges. Remember, for foot, there were tarsal, metatarsal, phalanges. Here, there are carpal, metacarpal, phalanges. We have a total of 8 carpal bones, 5 metacarpal, and 14 phalanges. The carpal bones are organized into 2 rows. There's a proximal row of 4 bones and a distal row again of 4 bones. Let me take you through the proximal row of 4 bones. We can use this radiograph to name them. So from the proximal row, we're looking at these ones. Laterally, from the thumb side, laterally, this is the scaphoid bone, followed by lunate, followed by triquetrum. And on top of the triquetrum, you can see zimebebana. The one on top is called pisiform. You can appreciate that here. Scaphoid, lunate, triquetral, pisiform. That's the proximal row of carpal bones. How about the distal row of carpal bones? So you can still name them from the thumb side. The one near aligned with the thumb is what we call the trapezium. This one. The one aligned with the index finger is what we call the trapezoid. The one aligned with the middle finger is called capitate. Then the one aligned with the other two is called the hamate. So here, this is the hamate aligned with the last two. Capitate aligned with the middle phalanx, and then, sorry, middle finger, then trapezoid aligned with the index finger, and trapezium aligned with the thumb. That's a distal row of carpal bones. All right, metacarpals are 5, phalanges are 14, and I've told you why 14. I've taken time to take you through bones of the limbs as well, because I don't intend now to do this when you're going to look at the topographic anatomy of the limbs. Take time, go through the bones of the axial as well as bones of the appendicular skeleton, once again at your own time. So that marks the end of the lecture on the skeletal system. And I think I'll stop there. We'll pick from there next time when we'll be looking at now articular system as well as muscular system.